Hello, everyone. Gavin here from Chinese Medicine Education and China Book Sydney. I'm here today with Rich Hazel. We're just doing a little bit of a chat today in lead up to our workshop that we've got coming up with Rich in March in Sydney. So this workshop will be a 4-day event. Rich will be taking us through motor points, but also in particular how we treat nerve entrapments. So in this talk, we wanted to hash that out a little bit more and get some insight into what to expect from the course. So the course is 4 days. Just to give you a little bit of information, it's going to be starting on March 29th, so that's a Saturday, to Tuesday, the 1st of April. Day one is going to be sort of like a introduction, core essentials. We're going to go through some neck protocols and upper cross syndrome. And then from day 2 to 4, we'll be getting stuck into nerve entrapment. So we've got day 2, upper limb entrapments and pain, a whole bunch of stuff there. Day 3 will be sciatica and related entrapments. Day 4 will be all lower limb entrapments. So it's going to be a very comprehensive kind of course, and I'm personally looking forward to learning this stuff. We've had Rich out quite a few times now, and this will be all new material, so that'll be great. So to get us started, I thought I'd sort of just hand it over to you, Rich, just to give yourself a little bit of a introduction for people who may not have been to your course or not really know about your work. So yeah, how did you kind of get into motor points and orthopedic acupuncture? And yeah, we'll take it from there.
So it's an interesting journey, and if you saw any of my courses when I first came to Sydney for China Books in, I think, 2018 or 17, was it 2018? That was
It
probably
was,
my first course.
yeah, I think so.
If you've been to any of them after that, you've probably seen a progression, because I'm continually learning things. And, as an acupuncturist, most of you can relate, we're usually the last resort for people in pain. They've tried everything that the doctor suggested. They've done physio, they've done injections, maybe they've even had radical surgeries, and they're still in pain. So, eventually they'll try anything because they don't want to be in chronic pain, and they come to us. And so what that's meant for me is that my knowledge that I gained when I first learned about motor points in acupuncture school in New York City has had to progress. I've had to learn from lots of different doctors who were successful at treating chronic pain. So to start, I was in acupuncture school in New York City, just like everyone else, to get a TCM education. And that is what I got, because that's what's required to sit for board exams and to get a license in the United States. But for a short period of time, there was a sports and orthopedic acupuncture program which introduced us to motor points. And if you don't know what a motor point is, it's basically the part of the muscle that's used for electromyography testing, for nerve conduction tests. A guy named Dr. Joseph Wong was the first doctor to change from acupuncture points to motor points to treat pain. He was a neurologist, a pain management doctor, had gotten his education in China, moved to Canada, and started to wonder if he could get a different response by using the motor points. And he did get an enormously better response by using the motor points. So Joseph Wong is really the first guy to do this. And that was in the 70s and the 80s, 1970s and 80s. My education was pretty cursory. It was enough to get good results in the student clinic. But when I graduated, I found that I had no mentors. There was no one who would talk to me about it. The Facebook groups didn't even know what a motor point was. They'd heard of trigger points, but they didn't know what a motor point was. So I kind of had to find my way. And with tough cases, I kept going back to Janet Travell's work on trigger points, myofascial trigger points, and pain referral patterns. So you'll see a lot of her work in my slides, because I still feel like Dr. Travell's pain referral is such a great shortcut to know where to look for the problem, especially for chronic pain. If you show me someone in chronic pain, I will show you someone who has active, painful trigger points. Um, which is not to say that everyone needs trigger point work, because there are a lot of athletes, there are a lot of people in acute pain that is not trigger points, and those are the ones we love because they jump off the table and they feel great. Um, when when I didn't understand enough to help some of the people, I could probably help 70 or 80% of people. But the ones that I got stumped on, I knew I needed to learn more. So I kept going back to Vladimir Yanda's work. Yanda and Carl Levitt were the Prague School doctors who said most chronic pain does not come from the discs. The muscle tension and muscle imbalances may come from the disc, but it's not the pain that's coming from the disc. It's the muscle imbalances that are causing pain. So they were really pioneers in treating chronic pain successfully by working with the muscles that become tight or weak, the tonic and phasic muscles. So I kept going back to Dr. Yanda and finding success by looking at his upper cross and lower cross syndromes to understand how the body responds to pain and overuse, age, posture, all these things. We see these patterns. And so you end up treating muscles that the patient is not aware of is part of the problem. Um, it's a functional approach instead of a structural approach. A structural approach says, oh, you have a shoulder bursa that's inflamed. Let's put needles and electric stim in the shoulder joint. The functional approach says, let's make that joint move better so that there's no rubbing and no inflammation that creates a bursitis. Let's fix the whole function of the whole upper extremity and maybe even consider the whole shoulder girdle. Maybe we even need to consider some of the hip posture that could be affecting the upper body. So it's a functional approach. If anyone is following me, you probably heard me talking about the fact that I've decided, instead of saying motor point acupuncture, I'm calling what I do functional acupuncture, because it distinguishes what I do from what a lot of the other people out there in orthopedic acupuncture world are doing, that I see as a little bit too structural, still fixated on the joint as opposed to correcting the imbalances and the movement patterns. So I always went back to the Prague School guys. Those are the keys to what I've been doing. Then along the way, I got exposed to Andrew Vlaming's work on SI joint stability and the myofascial slings and how they all stabilize the SI joint, and how proprioception is a huge part of mobility and movement, and how the body adjusts or doesn't adjust and gets injured. And it fit perfectly with how Yanda saw things. Yanda was very big on proprioception, the sensory motor system, how sensory input allows motor control. Without sensory, we don't have smooth motor control. Someone who can't feel their feet is relying more on their eyes and to be able to move without tripping. So Dr. Yanda was very aware of that. So he understood that injury could affect the sensory motor system. So you were not just working with muscles, you're working with fascia, you're working with the proprioception. And then Andrew Vlaming sort of filled in the gaps for me on what muscles are trying to stabilize the SI joint, which is hugely important because it's where the spine meets the pelvis and where force is going to be split between the two legs. Or as a runner, for instance, the force is going to be transferred back and forth, and you need dynamic stability of the pelvis in order to be a good runner and not have injury. And if you understand how the lack of good proprioception at the SI joint is going to affect injury, and mobility, and things like the psoas getting tight and starting to tilt the pelvis and putting more strain on the SI joint. Now the deep rotators are getting tight. You start to understand how to help people that other people have not been able to help because they were so fixated on sticking needles into that SI joint that they didn't really see the big picture, that SI joint pain was coming from probably the front of the pelvis in the psoas, tilting the pelvis forward, and then those deep rotators like the piriformis and the glutes, glute medius, all getting tight to try to stabilize the SI joint. So you end up working with a different methodology that actually works for your patient quickly. And this is why my treatment for sciatica is usually no more sciatica after the first treatment, some muscle soreness for the second and third, and then they're pain free. And it's because of Dr. Vlaming that I learned those things. Andrew Vlaming, I think he's Belgian, always studying the SI joint. And then, when you start having other patients that no one else can help, you start seeing a lot more of the nerve entrapments. You see people with foot neuropathies. You see migraines. And when I discovered Andrea Trescott's book, Dr. Trescott, she's in Florida. She's brilliant, and her book is it's just a gold mine for anyone who treats chronic pain, because you're going to suddenly understand all those things that you couldn't fix before because you didn't understand that what you were actually dealing with was a nerve entrapment. And you have to know where those entrapment zones are to even begin to correct the problem. So, one of the things that I'm going to teach in Sydney this time is about the superior gluteal nerve entrapment. I see it a lot now that I know it, now that I recognize it. If you've studied a foreign language and you learn a new word, suddenly you hear it when you're listening to something and you never noticed that word before. As soon as you recognize what a superior gluteal nerve entrapment looks like, which I'm going to tip you off, it's the nerve that innervates the gluteus medius, the TFL, and the gluteus minimus, which are important hip stabilizers. You'll see someone who can't stand very well on one leg. You'll see somebody who's had chronic pain into those muscles for a while. And you'll see somebody who, when you're used to seeing a good muscle response to your electric stimulation of the motor point, you'll see that it barely can fire. It's like it just can't get there. And once you see that, you know where to look for that entrapment. The most important one you'll find is right above the where the piriformis attaches to the sacrum. There's an ilium. There's the top of the iliac crest and the piriformis, like a little triangle. Deep in there is where that nerve comes out, and that's usually where the muscles have contracted so much that they're pressing that nerve, making the rest of the hip weak. Once you see that, you're gonna help people that physio wasn't helping. They just didn't know what to do next. So we'll talk about some of those nerve entrapments. The superior cluneal nerve. I see that now all the time. I remember one patient I had. She's a prison guard, and she had had an incident at the prison, and ever since then, she had pain on rotation that would go into her whole hip, the glute, upper glute, and around the side. And it was a superior cluneal nerve entrapment in the quadratus lumborum. And once, this had been a chronic issue for her, and nobody was able to help her. Physiotherapy was not exercising her way out of a nerve entrapment. And I think one session, maybe a second session, and it was fixed. We never even visit that issue again. I see her pretty regularly for maintenance, probably every 2 months. But once you know the nerve entrapments, you can address them quickly. You can assess them and address them. And if you don't address them, you'll be wondering why your patient's not getting better, because you'll muscle test and you'll say, oh, well, it must be the glutes that are weak. Let me treat the gluteus medius and the glute max. Maybe there's some, hip flexor that's shutting off the glutes, but you still won't find that problem. And the superior cluneal nerve, interestingly enough, somehow ricochets off of the spine and can create sciatica. Some people can get sciatica down into the hamstring from the superior cluneal nerve. And that's a really interesting thing, because the innervation is not shared with L5S1 like the sciatic nerve. So it must be bleeding over from L4 down into the L5S1. But it's a common pseudo sciatica that gets missed. And if you're doing your typical sciatica treatment, it's not going to help it, because the problem is higher up than what you thought. We'll, of course, be going through sciatica. I think everyone should be able to be successful treating sciatica in one treatment or two treatments. I saw somebody post something on Facebook. He was so happy that he had gotten someone out of sciatica in only 10 treatments. And I was like, oh my God, really? Like, that's probably either 5 weeks or 10 weeks, but it's a lot longer than I want to wait if I have sciatica. So we'll consider sciatica as one of those nerve entrapments that we want to discuss. It's one of the most common ones that people know. I've come to Sydney twice to teach the nerve entrapments that cause migraines. I still have great success treating migraines by treating it as nerve entrapments. But we're going to cover some interesting other ones that you probably see a lot, and you're either sending them away for imaging, or you think they need a surgery for carpal tunnel, but they may not. There are nerve entrapments in the arm that can imitate a carpal tunnel, like numbness in the palm. There are people who, I don't know about you guys, but I think I see when I see entrapments that cause numbness in the hands, it's usually just at night. It's usually that they just have, like, their hands go numb at night. It's not like they're walking around with numb hands, but it's very frustrating for them that they wake up and they have to, like, shake their hand and try to get blood back. And a lot of that is nerve entrapments, and much of it is coming from the thoracic outlet. So day one, we'll be looking at the upper cross syndrome, and that will lead us into the treatment for the thoracic. It's called neurogenic thoracic outlet, because we're not trying to fix the compression of the artery. When someone has that artery compression, they need to be in the hospital. But when it's a neurogenic thoracic outlet, it's usually not constant. It's usually positional. Certain positions, like they can't raise their arm without their hands going numb, or they can't do certain exercises without their hands going numb, or they wake up in the middle of the night. And that's an important one to know how to treat. That thoracic outlet that neurogenic thoracic outlet can be what's called a double crush, that leads to muscles down the chain getting tight, and then now you have a cubital tunnel, or a pronator teres syndrome, or maybe something in the deep radial nerve. There could be tingling on the back of the hand, but those could be secondary to the neurogenic thoracic outlet. So you need to know what you're looking for. So we'll be covering that. We'll go through how do you assess, how do you figure out if it's from the elbow first, or if it's from the elbow because of thoracic outlet, or if the thoracic outlet's not involved, maybe it's something from the neck. So then we want to go through that thought process so that we get the best results. I would say always treat the thing that's going to get them the most relief first, and then look for the causal issues in your follow-ups. You can, when they're starting to feel better, then you start looking more at the upper cross syndrome, more at their postural things that led to that problem. I always want to give them the most relief up front, and then talk to them about how it happened and what we need to do so that it doesn't come back. So we'll talk about that sort of stuff. But those doctors have been the most important to me getting good results for my patients. I swear it's like the universe knows that you can help that person, because like I see people with these nerve entrapments and nobody knew what to do for them. And when they go back to their neurologist and they say, well, my acupuncture, which must be like such a joke to them, my acupuncturist thinks that it's an ilioinguinal nerve entrapment. Can you do something? And they'll say, no, we don't treat that. That's, I had somebody who has had his entire cervical spine fused. His whole neck has been fused. Um, and he gets numbness when his hands go up to do physiotherapy. And I said, okay, well, that's just like the ruse test for a thoracic outlet. Let's treat you as if it's thoracic outlet and see if we can get better improvement so you don't have numbness in your hands when you exercise or in the middle of the night. And then he tells his physiotherapist, my acupuncturist thinks it might be neurogenic thoracic outlet. They said, let's do some testing. And they do the test and they say, yeah, I think that's right. Let's start working as if it's that. And then he goes to his neck surgeon and he says, well, my PT, we say PT for physical therapists, but it's not a personal trainer. My PT and my acupuncturist think I have neurogenic thoracic outlet. And then his doctor says, well, I don't treat that. That was it. Get out of my office. So when you start knowing what you recognize and you know how to treat it, somehow those patients will land in your office because nobody else figured it out. And you start having success, and then maybe word of mouth, or somehow the universe says, you're like, go to this person, because like I spot what they have and I'm able to help them really quickly. And they've been set aside by doctors, because if a pharmaceutical can't help it, then you're kind of screwed. If there's not a surgery that they could do because the MRI looks good, or they've done a surgery already, and there's no pharmaceutical for you, you're kind of in trouble. And a lot of peripheral nerve entrapments are not going to show up on an MRI because it's a muscular entrapment of the nerve. So they're lucky if they find somebody who knows how to help their nerve entrapment. Um, I think what the last day that I'm teaching in Sydney, hopefully people are not planning to leave at 3 p.m. to catch a flight, because we're going to be covering stuff that's a gold mine for you if you treat people in their 60s and 70s and 80s who have foot neuropathies. I use Dr. Truscott's nerve entrapments to figure out how to help people with their foot neuropathies, and I get really good results. Sometimes 70, 80, 90% of their feeling back if they had numbness, and the pain will go away as well by looking at nerve entrapments. The tibial nerve can get entrapped, that causes numbness in the bottom of the feet, and then the superficial peroneal nerve that covers the front of the shin and the top of the foot can also get entrapped. And what I find is that the neuropathy is a combination of tight muscles because of their age, and those leg muscles get more and more tight, and ischemia. I think it's just probably part of our aging process that those soleus muscles that do not fatigue become so tight and ischemic that there's no blood supply for the sensory nerves. They just stop feeling. So what you're doing with your acupuncture treatment is getting blood circulating so that the nerve has a blood supply, and you're taking pressure off of those nerves so that they get sensation back, and you get rid of pain if they have pain. I think it's pain first and then numbness, because that's how it backs up when you're treating. When you're treating someone with numbness, they may have a week where they had some pain. And then as you treat, the pain goes away. But they get their sensation back, and that could mean a little bit of pain. But you'll get them out of it by continuing to treat. So so hopefully people aren't leaving too early on that day, because I think somebody who was motivated could probably open an acupuncture clinic that only treats foot neuropathies, because when you know how to do that, it's in high demand. And your patients will tell all their friends because they have their cohort of people their age who also have the very same problems. So thank you, Dr. Truscott, for that. I don't even know if she knows that acupuncture can treat foot neuropathies, but I basically followed her book on how she would treat with hydrodissection for nerve entrapments. That's an injectable that can clear the pathway of the nerve to basically free it up in the fascia. But I mean, I'm still in a learning process. I'm still always learning. But if you're coming this year, you're learning something that I may not have been able to teach you before COVID. A lot of the stuff I learned from Dr. Truscott has been since COVID. So these nerve entrapments are somewhat new to me, relatively. Mostly probably 21, 22, 23 is when I was really digging into her books and learning this stuff. So you won't find other acupuncturists, I don't think, who are teaching it. I don't see them talk about it. I'm in the Facebook groups that talk about orthopedic acupuncture, and very rarely do they even know what I'm talking about when I suggest maybe it's ilioinguinal nerve entrapment, because someone has, you know, pain in right below the rib that goes into the groin, and they might have some nausea, they might have some sort of pelvic floor symptoms, urinary urgency, things like that. Some of that stuff that gets blamed on the pelvic floor can be nerve entrapments like the ilioinguinal nerve. Um, Sometimes adductor magnus trigger points can cause urinary symptoms, urgency, or what's called stress incontinence. There are a lot of things that I've learned from Janet Travell and her trigger points, and Dr. Truscott, that go outside of pelvic floor and even pudendal nerve symptoms. There are other nerves that can create some of those similar symptoms. So I get those patients, and those ilioinguinal patients, a lot of times they're much better after couple treatments. We're going to be covering lateral femoral cutaneous nerve. Most of you have seen it, and you probably just didn't know what to do about it. When someone has, it's called what is it called, parasitica neuralgia or something. It's the neuralgia parasitica. It's the numbness in the lateral upper thigh area. If you have overweight patients, they're prone to this, because when your belly kind of overlaps a bit of the ASIS and pelvis, that's where that nerve comes out, and it can get compressed there. So tight pants, tight belts, and a little bit of a belly. Sometimes it happens for pregnant women too. There can be pressure there where those nerves come out, and then they have numbness in the thigh. And if you're trying to treat the thigh, I mean, I don't think there's anything wrong with treating the thigh. I think once you're unentrapping those nerves, it's a great thing to treat that vastus lateralis area, because you want to get the blood flow back and you want to get things firing better. But it's not the only thing to treat. You've got to know where those nerves get entrapped, usually in the sartorius, iliacus area. And then we'll go through like how to know where to put the needles, because that nerve is not the same on everybody. So it's a palpation skill, and we don't need a person with that exact problem to learn how to do the palpation. We just need a partner who will let us poke our fingers around and feel what those muscles feel like and where those nerves are going to get entrapped. But that's a really common issue you're going to find. A lot of us probably get away with not being able to fix it because the patient's kind of given up already, but a lot of times we can really help that. And it's not always numbness, by the way, it could be pain, burning.
Yeah,
So
actually, just talking on that one, it reminded me a few years back, I had a pregnant lady who had that exact issue. And yeah, we really struggled to get much of a difference there. So that'll be really interesting to go through some of that palpation and assessment kind of stuff that you're talking about.
yeah, definitely.
Have you treated it with pregnant women before? So I guess you have to be a lot more careful.
Not during pregnancy.
Mm.
The most common thing that I end up treating for pregnant, sorry, my dog is vomiting. For pregnant women is always going to be sciatica because of that anterior pelvic tilt causing the deep rotators to get tight. But you can treat a pregnant woman without electric stim and get good results.
Mm.
I think for the lateral femorocutaneous nerve, after her pregnancy, you'll get a better response because using electric stimulation is really the best way to free up where those nerves pass through. And I
Yeah,
wouldn't probably want to dry needle a pregnant woman.
no.
So
Yeah, that was actually going to be one of my questions. So with the nerve entrapments, I mean, you're well known for using like motor points. Is that what you're using when you're treating these nerve entrapments, or are you, yeah, using trigger points or a different kind of approach?
sometimes you have to use trigger point, dry needling, trigger point release. So, like for the superior cluneal nerve entrapment, it's almost always going to be a trigger point in the lower quadratus lumborum area, right where it attaches to the pelvis, right above that, almost every single time. Um, and we'll do that. I'll show you how to safely do it and what angle you're going to use and how to palpate it and actually find where that issue is because the patient has pain when there's a sensory nerve like the superior cluneal nerve is sensory for the upper gluteus maximus area wrapping around a bit to the side. And I should have probably said that back when I first mentioned it. It's sensory nerve. So the pain is going to be around the iliac crest when there's an entrapment and irritation. Sensory nerves that are entrapped become hypersensitized. They're trying to feel when they're having a hard time because they're being squeezed. So they become painful. The muscle around the sensory nerve becomes painful, which is how we find the nerve entrapment. So the palpation is around that iliac crest. And then you're going to find in that lower QL area a very sensitized trigger point. And then when you release that trigger point, they should be pain-free in the iliac crest. I will sometimes still treat right around the iliac crest to kind of neuromodulate to try to calm down the nerve. But I think if you were interested in doing research and not just trying to provide relief for someone who's giving you money to do so, you might try just releasing that trigger point and see if it helps. But I don't tend to experiment when I know what will work and somebody's giving me money to get them out of pain. Um, I think just freeing up that entrapment would be sufficient for most people. Um, so what else? So we're going to talk about arm entrapments. We're going to talk about um, the the obturator nerve entrapment. I think I did that once with you guys, but acupuncturists are probably familiar with seeing a patient who lies on their back and one leg flops out. I'm sure you've
Yeah,
seen
I see
this.
that all the time. Yeah.
Everybody's seen this, right? So why does that happen? The obturator nerve can get entrapped by muscles in that adductor canal area, and the obturator nerve innervates the adductors. I mean, the anterior adductors share innervation with the obturator nerve and the femoral nerve, so they can act as hip flexors. The posterior, like the adductor magnus, is obturator nerve and sciatic nerve, so that it can act as an extensor. But the gracilis is all obturator. The abductors are able to internally rotate the hip and maintain alignment with your toes straight forward. When they become weak because of that entrapment of the obturator nerve, they can't hold the knee in place. They can't hold the foot in alignment, and it flops out. So I used to see that and just say, oh, well, whatever. I guess that's just how your hip is. I didn't know what to do. But, after studying Dr. Trescott, I know what it is. And I've seen people for whom it gave them excruciating pain to lie on their side, to have that nerve entrapment. I had one patient who walked like a cowboy because he had to swing his legs out. It's called circumduction. When your adductors absolutely do not work, you have to swing your leg out when you walk. It's a funny looking thing, but he had to walk like a cowboy with his knees pointed out. And I unentrapped the obturator nerve on both sides. And he not only no longer had sharp testicular pain when he laid on his side, but he could actually start to walk more normally. He had had some spinal lesions and some surgeries that led to this problem. I don't think it's a typical like injury you're going to see on most people, but like I said, when you know how to fix something, somehow the universe sends you that person, and there they are. And it's great. One or two sessions treating that issue, and they're hugely improved and no longer having sharp testicular pain. It's a nice thing.
That's a
He
bonus.
said he said lying on his side was excruciating. So we'll be talking about that. There are a lot of nerve entrapments that I think most acupuncturists see and don't know that it's what they're seeing. At least that was the case for me. There's a lot of these things that I just sort of saw and didn't really know what to do about it or what it was. One of the things that we ignore is when someone says they feel burning or tingling. Burning and tingling are nerve. That's all day long nerve. So it's easy to have somebody point to their IT band and say they have burning, and you think, oh, it's fascia, it's the IT band. Let's treat it as IT band syndrome. Then we'll treat those abductors of the hip and the piriformis and the glutes and get their hip functioning so that they have less pulling on the IT band. Maybe you're going to treat vastus lateralis like you would for an IT band syndrome, but you might be missing a lateral femoral cutaneous nerve entrapment that's causing burning down the side of the leg. Someone else has numbness. This person has burning. So now we need to look at the sartorius. We need to try to figure out where that entrapment is that's causing burning down the side of their leg. So those are things that we all see, and we just kind of write it off as the patient described it as burning, but I know it's just a fascia burn. It's just like a fascial pain, and you might be missing a nerve entrapment that's actually something you could fix fast. So
Yeah, that sounds, yeah. I mean, just hearing you talk, I can think of like cases in clinic where I've struggled to get changes, and I think what you're talking about would be able to. So I'm really excited to have you come out and teach these nerve entrapments for myself. One thing you kind of touched on a little bit was the like people can get pelvic pain kind of symptoms. And I think that's one thing that we see a lot as acupuncturists, but we're not necessarily thinking about nerve entrapments or trigger point referrals or stuff like that.
right.
And I remember some years back, one of the courses that you did, we went into like pelvic pain, and there's actually a lot that the muscles around the pelvis can refer in terms of pelvic pain and stuff like that. And so
Right.
yeah, that's an important one to
Well,
consider.
I will be briefly covering the pathway of the pudendal nerve because of the possibility of a piriformis and obturator internus entrapment of the pudendal nerve. So definitely going to cover that, but I'm also going to cover the trigger points in the adductor magnus that can create a lot of those same symptoms. There will be some discussion of that and some of the pudendal nerve symptoms, but you'll see how they can also overlap with the ilioinguinal nerve. Um, when someone has what looks like pudendal pain, there's going to be, it's all genital stuff, it's all orifices, and the strength of them. Sometimes that can also be coming from these other nerves like the ilioinguinal nerve, because they go into that same area. Learning how to differentiate them based on the symptoms will be important. um, but the when it's a piriformis or obturator internus um, pressure on the pudendal nerve, you absolutely will see an improvement for that patient. There are other entrapments that will more likely need something a little more invasive to free up the pudendal nerve. But it's just good to understand those symptoms because you will be surprised how many of your patients actually have symptoms of a pudendal nerve entrapment, and the doctors are still considering lumbar plexus and wanting to inject the lumbar plexus and have not even mentioned the word pudendal to their patient. And if nothing else, you can be an advocate for someone who's been undiagnosed with, pudendal nerve symptoms for a year or two, and nobody has mentioned it. And then they go back to their doctor and say, "Do you think it could be my pudendal nerve?" And then the doctor sees a light bulb and says, "Oh, maybe we should investigate that." And the way that you diagnose that, by the way, it's a clinical diagnosis. They do a temporary nerve block to see if that's what's going on. There's no MRI that's going to see a pudendal nerve entrapment, which is how it goes undiagnosed for a long time. They're still looking at your lumbar MRI. So even if you can't fix it, you can advocate for your patient who has gone undiagnosed for years, and all they have is gabapentin and Lyrica or whatever drugs that do not work. So yeah, we'll talk about that. And some of this stuff I don't claim to be able to fix, but at least if you can recognize it, you're helping your patient. You're moving your patient forward to hopefully the specialist who knows what to do.
And so, how are you handling people who come into the clinic and they've had scans and maybe there's some like degenerative changes in the spine, and they're convinced that it's a structural issue, and that maybe surgery is the only way to go or an injection or whatever? How are you handling people with those kind of expectations and sort of getting them on board?
That's an interesting thing because we do have to deprogram our patients. They've not only have they been told nothing can be done for you, but they've been told that, well, with your amount of arthritis in your spine or your amount of stenosis, there's really nothing can be done for your pain. So I go back to Dr. Stuart McGill, who's like the back doctor researcher. This is on my website now because it's that important. And he studied the spine for years. He's still like one of the best known spine experts. And he says most pain is not coming from your discs. The pressure from the disc can cause muscle imbalances, but you got to treat the muscle imbalances. That's exactly what Vladimir Yanda said. So what I would tell them is, you don't need to believe me, but I'm going to explain what I'm doing so that when it helps you, you will know that your pain was actually solvable by treating these muscle imbalances. And I see seniors all the time who have had sharp pain in L5. They have the MRI to prove that that's the problem. I think if you did an MRI on me, I probably have some disc issues at L5. Okay. We're an upright species, and our L4-5 is going to get crushed. And if you get to live more than 4 or 5 decades, you probably have an L5 issue. So when you have pain that matches up with that, they blame the disc. And then they may have even done injections. They may have done something invasive, and it didn't help. So that pressure on L5 is going to cause a lot of muscle tension down the chain. And one of the most common things that I'm seeing is trigger points in the gluteus medius, right by the sacrum, where the sacrum, right off the edge of the sacrum. And if you follow the fibers of the gluteus medius toward L5 and you press really deeply, you'll find these really painful taut bands in the gluteus medius that are actually the source of their pain that they feel at L5. And you release those gluteus medius trigger points, and their life is changed. They cannot believe they can sit up on the bed and they feel no pain. And when they walk, they feel a little soreness from your trigger point release. They have no more pain. I just had a patient who came for me for neck pain, and she didn't tell me about SI joint pain because she already had that handled by a different doctor who did injections for her every 3 months for her SI joint pain. So she would get these cortisone injections every 3 months to be able to live, because without them, she has constant SI joint pain on the left side. She mentions it to me. I've been seeing her maybe 4 or 5 sessions for her neck and traps and all this stuff, right? Headaches are gone, neck is great. Physiotherapists can't believe how good her muscles feel and her traps and everything after we've done all that release. And then she mentions her SI joint injection getting rejected by her insurance. And I'm like, what is this about your SI joint? What are you talking about? She's like, oh yeah. And she tells me the story. I said, did you ever tell me this? She's like, no, I just didn't even think it. I didn't think nobody has been able to help it. She said, I used to get acupuncture for my SI joint. I probably went to her 100 times and it never helped. Like I kept going, hoping I would find relief for this pain that I've had for years. I said, okay, hold on. I found those trigger points. I released those trigger points. Next time I saw her, she said, my life has changed. She said, like she could walk, she could stand, and she didn't have constant SI joint pain. She had a little bit of soreness still. I treated it a second time, gone, done. Now, of course, I'm going to tell you, I have been working on her psoas, her hip flexors, her TFL, all these things. So I'm correcting for the tilts that led to the problem. But I just want to say, like, the source of the pain was in those trigger points. Now I'm trying to make sure that it doesn't come back because there's no SI joint strain that leads to those glute medius trigger points. But she can't believe it. And she's been getting injections. She's been paying, her insurance would cover 2 per year, and then she paid the other $400 each injection for the other 3 months, so she could do it every 3 months for years. And she's not old. She's like 40. So when people have been brainwashed, they tend to not tell us that they have something because they already know that nothing can be done. The doctor already told them, wait until you need a knee replacement and then come see me. They don't tell us about the stuff that the doctor already told them. Nothing can be done. You're bone on bone. There's nothing that can be done for your chronic. Then they kind of, after they've been seeing you for something and they see that what you did corrected it and didn't just relieve pain for a week or two, then they start to say, do you think you could do you think you could help knee pain? They said, I have terrible osteoarthritis. I know my doctor said I'm going to need a knee replacement. Probably nothing can be done. I should lose weight. They tell me all the things they've been told. Then, we treat their hips and their quads. They're good. Now, that person with osteoarthritis needs maintenance. They should come every month, every 2 months, whatever works for them based on their activity. I'm not saying I can correct it and it's solid, especially at 60 or 70 or 80 years old. Those muscles are going to get tight again really fast, a lot faster than for most of us. They've lost a lot of their fast twitch fibers. They're more prone to muscle shortening because slow twitch fibers are the ones that shorten. So I'm not saying it's permanently better. I'm saying it's pain free until next time I see them, which might be a month or two, and they do really well. So yeah, we have to kind of deprogram our patients and get them out of the mindset that nothing can be done for them just because the experts who make a lot more money than we do have said nothing can be done for you. You know, that's one of the reasons I decided to call what I do functional acupuncture, because it's important for the patients to understand that my approach is different from the structural approach. I'm looking at how your body moves, and I'm trying to correct the problem that led to the pain and the rubbing and the joint issues that caused inflammation, pain, um, soft tissue
Yeah.
degradation. So
I mean, it makes me think of like in Chinese medicine, we have this idea of like root and branch treatment. And I mean, the root would be the movement patterns that lead to the branch of the joint manifestations a lot of the time. So
correct.
that makes total sense.
Exactly.
Yeah.
Exactly. Yeah.
Yeah. All right. I'm mindful that you need to race off for another call.
Yes, I have to do
Thank you so
another.
much for your time this morning. Before
Yeah,
we
sure.
wrap up, do you want to just share? I know you've got like a podcast and some other things going on. If
Yes.
you're interested to find out
Yeah,
about.
I don't know if you guys saw on social media, my podcast was nominated number 6 out of the top 15 in the world for acupuncture podcast, the Acupuncture Outsider. It's on all platforms. And then I have online courses at richardhazel.podia.com, including a mentorship group. So, if somebody's studied with me and then they want to, which is actually what my next Zoom call is, my Zoom meeting for, I do 2 per month. The one I do on my Monday evening is Tuesday morning in Australia, so that my Australian people can join in for the mentorship Zoom meetings. Then we record them, we post them in the group so people can watch them at their leisure. Um, so yeah, so I'm doing some online stuff, and the podcast is free information. I put out as much information as I can for free in this podcast. I'm not holding back. I'm not trying to upsell you on something. I'm just telling you what I do, how I did it, what my patients said about it, and then hopefully it will help people who have patients with a similar issue.
Okay. Yeah, I really appreciate that kind of functional approach of and all these different orthopedic sources that you're bringing into acupuncture. I think it's really valuable. So, yeah, if anyone was
Thanks.
interested, the 4-day workshop that we've got coming up with Rich in March is going to be a good one. I mean, I think one of the best ways to learn some of this stuff is to get hands-on, because Rich is going to be there, and we'll make sure that everyone gets hands-on and starts to palpate these things, can assess these things, and then treat these things. So yeah, if anyone's interested, it'll be in Sydney, Saturday, March 29th to Tuesday, the 1st of April. Yeah, I think that'll be a fantastic one. We also do have like recordings of other times that Rich has come and taught with us on Chinese medicine education. And if you're watching this after March, we'll be putting up a recording of the event as well on ChineseMedicineEducation.com, so you can find all the information there. And yeah, thank you very much for your time today, Rich,
Thank
and
you. Thank you.
have a good
I'll
evening.
see you very soon.
Yeah, see you very soon.